Good afternoon, everyone. Welcome to our webinar this afternoon. I'm just going to give it another 30 seconds or so just to allow the last few people just to come in and then we'll get started. So good afternoon, everyone, and welcome to the launch of our updated best practice in dementia care facilitator training. Just some, I suppose, housekeeping before we start. Sadly, all your cameras are off and your mics are muted. So although I would love to say it's lovely to see everybody, it's lovely to have you here this afternoon. I'm going to share my screen shortly, which will just start the presentation. We do understand that there will be a number of people that are on the webinar this afternoon that have never accessed our best practice facilitator programme before, but there will also be current trained facilitators. So welcome to you all. There is a Q&A part next to the chat function. You'll see a little symbol that has Q&A. Please feel free to pop in specific questions into there. We will try our best towards the end of the session to answer as many questions as possible, but I have also put the Dementia Services Development Centre, or DSDC as it's also known, their email address. So if there is anything that we don't manage to get to but you want an answer to, then please feel free just to drop us an email. So I shall share my screen and we'll get started this afternoon with the presentation. So hopefully everybody can see that presentation, and again, welcome to our webinar launch of our updated best practice in dementia care programme. Just to give you a bit of an overview of today's session, we only have an hour and hopefully we won't overrun that, because I understand that people are probably sitting in their workplace, or you're maybe sitting even having your lunch right now and utilising your lunch break to come on to this webinar. So we're just going to provide a very brief introduction to the Dementia Services Development Centre, or DSDC as it's known. A little bit of a history of the best practice facilitator training programme, just to give you a little bit of background context. And then I'm going to then hand over to my colleague Lindsay Dingwall, who is a new associate within DSDC and joins a whole bank of other associates that we have, which again, you'll come into contact with during your time within the best practice facilitator programme, should you wish to come on board with us. I'll then provide a little bit of an introduction to myself. We'll then give you a slightly more in-depth overview as to the updated course and new things and where our updates have taken place, and then just some opportunity for some questions as well. Feel free to populate the Q&A part with some questions, and my colleagues Ailey and Lorraine are standing by to answer questions as we go through, but also we'll take some time towards the end to answer anything specific. So to give you a bit of an introduction to the Dementia Services Development Centre, the centre itself, as a centre, we have a global reputation for our ageing and dementia research and our knowledge exchange in dementia design and care. And it's effectively our job here at the centre to translate what can often sometimes be quite complex research into tangible outcomes for practice to help improve the quality of life for people living with a dementia and their care partners. We situate ourselves within the Centre for Environments, Dementia and Ageing Research, or CEDAR, and we conduct multidisciplinary research focused on the social, built, natural and care environments for older people and people living with a dementia. The centre itself was formed in 1989, and the whole basis as to why the best practice programme then evolved was our mission, and that is to improve the lives of people living with the dementia through research translation and knowledge exchange, both nationally and internationally. So how do we do this? Well, in the past, we would often tend to find that our practice didn't really change unless there was proven research outcomes. And to a degree, that is still the case. But DSDC has deliberately centred itself in the approach that actually practice has to inform research. That's vital in us to be able to continue to offer best practice guidance to a whole range of different clients, both nationally and internationally. And we use what practitioners tell us, including people within the facilitator programme, to help inform what our research areas of interest should be going forward to hopefully make a difference to the lives of people living with the dementia and their care partners, but also to you as a practitioner. How do we do it? Well, we do it through a number of different strands. I'm not going to go into every single one of them today, but a number which we feel are very pertinent and we would like the opportunity in which to speak to you just for a couple of minutes today would be around our consultancy services. So we act as consultants to a range of different organisations, both nationally and internationally, whether that be on the design of environments or whether it be care consultancy as well. We have an Environments for Ageing and Dementia Design Assessment Tool, or EDAT. What that tool helps us do is audit environments, effectively look at every environment from the eyes of the person that's living with the dementia. And it's backed by over 35 years worth of committed research, which both the University of Stirling and DSDC have been committed to for decades now. We have our dementia education workshop for family care partners and volunteers, and although sadly at the moment this is only limited to Scotland because of funding that we have, our view is that we now need to share this wider throughout the country. And it's an opportunity for us to disseminate research, but also changes that people can make as care partners when they're supporting their loved one living with the dementia. And then in the afternoon session, we ask a range of multidisciplinary professionals to speak for 10 minutes and then answer direct questions from care partners. And that's been hugely successful for the ones that we have facilitated over the past year and a bit, where social workers, it could be police officers, welfare rights, community mental health nurses can directly tell care partners, this is how we can help and we can support. The last 2 points, I'm definitely not going to labour on the Best Practice and Dementia Care Learning Programme, because that's the whole reason as to why we're here today. And then there's our product accreditation, so we can accredit a range of different products, which again help us to make a difference to people's lives. So we thought it would be beneficial just to provide you a little bit of context as to the history of the Best Practice Programme. So our Best Practice Programme is award-winning and it's been running since 2007 and is used by organisations globally. The course was designed to increase the knowledge and skills around how practitioners support the person living with the dementia to effectively maintain control over their lives. Underpinning this is a person-led approach to care which focuses on the needs of the individual. We do this by operating a cascade learning approach. So if you join us on the facilitator programme, which I'll explain a little bit more about as we go on today, it's your responsibility to then take that learning and cascade that learning throughout your organisation. The course is fully research informed and we have a very mixed demographic of learners. So it's not a big all singing, all dancing academic course. We want this to be accessible by as mixed a demographic of practitioners as possible, and very proudly accredited by the Royal College of Nursing. The figures that as of November 2024, we have over 2,000 facilitators, trained facilitators, and over 13,000 learners, literally from Aberdeen to Zambia. So they are here, there and everywhere, and we hope that you would join us on this journey. I'm now going to hand over to my colleague Lindsay, who is just going to provide a little bit of an introduction to herself. Lindsay.
Thank you, Dave, and thank you for taking the time to attend this webinar. So I'm Lindsay Dingwall, and I've only recently joined the Dementia Services Development Centre as an associate in older people and frailty, and it's an absolute privilege to be here with Dave and with current associates, and also following the footsteps of the people who initially developed this programme and are currently working on it. Virtually all my career has been in caring for and with older people, and I've worked in lots of care settings, mostly across NHS Tayside. I also worked in undergraduate and postgraduate nurse education at the University of Dundee, and again, mainly my remit there was older people nursing and people with long-term conditions. Now, you'll probably have gathered that I'm not in the first flush of youth, and it's actually quite sobering to realise that what I've been teaching all these years is actually true. I retired in 2020 as the clinical academic nurse consultant for acute care in NHS Tayside, and after that I went and worked briefly in the private sector in practice development and clinical care quality. Over the years, nursing has changed. But before I go any further, I would just like to say that I am very, very aware that not all people living with a dementia are older. There are, of course, people living with a young onset dementia and or rarer dementias, but my role in this programme is to address ageing for people living with a dementia and that may be associated with being older. So over the years, it's finally, and I mean finally, been recognised that older people, people living with frailty, people living with a dementia, and especially older people living with a dementia and frailty are among the most complex and vulnerable groups who will almost inevitably become patients or service users in a variety of care settings, including their own homes and community settings and in hospitals. Nursing has seen significant changes in attitudes towards nursing older people. For example, where care is provided and models for care provision. But back in the day, nursing students didn't have any placement experience in what they then called geriatric wards because it was seen as too basic for staff nurses. And I actually can't believe that staff nurses were too clever to look after older people. But nowadays, thankfully, there's a recognition that to meet the complex needs of older people and people with frailty, we actually do need specialist education. And the journey for dementia care has been very similar. And this best practice and dementia care programme will contribute to you or your team's skills and knowledge. So in addition to building on the materials relating to ageing in the programme that Dave will explain later, my role is also to support with the reflection and leadership aspect of the programme and to oversee some of the discussion boards. And I know from my own experience that discussion boards can feel incredibly daunting. Writing anything public can be a bit scary, but it's especially if the first post has got what you wanted to write, but in a super intelligent way. However, when we learn from each other, and discussion boards are a great way to connect with each other while taking an online course like you will be doing. But the important thing to know about my role is that first and foremost, I'm here to help. And I hope very much that I meet you or your team on this programme in the future. So with that, I'll hand back over to Dave and thank you for listening.
Thanks so much, Lindsay. I'll just provide to you a very brief introduction to myself. So my name is Dave Wilson-Wynn and I'm the Senior Dementia Consultant based within the Dementia Services Development Centre. My role takes on various different strands. You'll have seen within the image that I put up earlier on, a lot of my work features within a number of these areas. So I support with things like product accreditation, the best practice in dementia care course that we have, but also I teach, lecture the undergraduate nursing and paramedic science students here within the university. The University of Stirling is very proud to be the first UK academic university to host a mandatory module for all nursing and paramedic science students here within the university, and DSDC is the leader in the development and also the delivery of that module. It's a huge privilege to be in front of you today, purely on the basis that having gone through the updates with Lindsay and with other colleagues involved both internal and external to the university, we're just very, very excited to be able to showcase this to you. And again, like Lindsay, I look forward to hopefully seeing as many of you on the course as possible in the coming weeks and months. So I wanted to give you a little bit of an overview. Effectively, why have we done what we've done? We've done it and we've reflected the course to reflect the needs of people living with the dementia and their care partners globally, because that's vital. We're an international centre. Yes, we're based within Scotland, and Scotland has a lot of additional frameworks and policies and things, but actually it's about us being able to look at people all over the world, because again, when I'm speaking about the wide demographic of people who access the course, it's not just people in Scotland that access this course, thankfully, because we can also utilise people within a whole host of other countries and perhaps maybe issues that they're facing or things that are going really well to help us inform our work going forward. We've used global policy. So Alzheimer's Disease International publish their reports every year, and it's really, really important for us to not reinvent the wheel, for us to look at what is mainstream policy and guidance and almost mimic that and disseminate that to you, utilising some of the specific research that we have here within the university and to help us inform the content and the delivery of it. We've now actively involved individuals living with a dementia in the updates, the new content development and the delivery of the programme. And that's been hugely rewarding. Interviews, which we've now recorded, will now form part of your learning. So you'll hear direct from people living with the dementia and their care partners as to their journey and their story, and hopefully the considerations that you can think of as practitioners. And very excitingly now, we're in active conversations with several influential organisations, including Alzheimer's Disease International, the Hilton Foundation, Care Inspectorate, the Care Quality Commission, to help make our course part of the national and international teaching in dementia care, because again, for us, that's absolutely vital. The updates in 2025, the first point being revalidation. So this is new to the course. So for anybody who accessed the course pre-2020, we would ask that they take the course again, purely with the sheer amount of updates that we have made to the course. The reason that we're asking for the revalidation is, one, from a quality assurance point of view, but two, to make sure that what we have out there are the very best research-informed facilitators. That would then feature, so you would receive your certificate of completion, and that will be valid for 2 years. So you will have then that period of time to continue to be a facilitator, and then you can join our revalidation course, more details of which will be released in the coming months, probably around the autumn. We've updated the research that's included in the content. Anybody who's on this call, I'm sure, will be aware just how quickly things change. And to then look at the third bullet point of even updates within global policy, things are shifting all the time. And although Scotland is regarded as a leader, it's up to us to, and it's our commitment to people living with the dementia to ensure that whatever it is that we are learning about, that we cascade this out to you as practitioners to hopefully influence your day-to-day practice. We, of course, have our Scottish Dementia Strategy, and we were very privileged at the University of Stirling and the Dementia Services Development Centre to conduct the literature review that helped inform our strategy. A number of us within DSDC are very privileged to sit as advisors within the Scottish Dementia Strategy subgroups, and we sit and we listen very actively to what people living with the dementia and their care partners tell us. We've used that learning and we've included that within the updates. So effectively, it's our opportunity to be able to say, the lived experience voice is very much there. And above all, we've listened. We've listened to what it is that you have to say, and we'll make sure that practitioners are also aware of that. We have some very new interactive content, so bite-sized teaching videos. It's about us being able to, I suppose, minimise the amount of extensive reading that we know sometimes comes with online courses, and make sure that the teaching content is very valid, it's up to date, but it's bite-sized enough for you to be able to take that video and remember the content that's there. We've utilised a number of multidisciplinary professionals, from clinicians to faculty staff, care home specialists and health and social care colleagues, because again, we wanted to ensure that we're listening to those who are on the front line right now, what's working and perhaps what's not working within day-to-day practice. All our units have been reviewed, and we have some new additions. So we have dementia, the journey. We have underrepresented communities within dementia. So that's focused on a lot of work we've been doing right now within the LGBTQ+ community, but also for veterans and people who have served in the armed forces. We have a new standalone delirium unit. So there's a number of newer additions here that we're looking at. And also the fact that just re-emphasising the importance of these underrepresented communities, because again, we've listened to what they've got to say, and we've used that to help inform what the content is going forward. So how does it actually work? For those that perhaps aren't aware, is that DSDC will train a nominated person from your organisation by attending our Best Practice in Dementia Care Facilitator programme. And once trained, we refer to you as a facilitator. On completion of the online programme, each facilitator is then provided with resources for 8 learners plus their facilitator guide, which is included in your course cost. The facilitator will then return to your organisation and will take a team of staff between 4 and 8 learners through the programme. So this is why I talk about this cascade approach to learning. The online content you'll have access to for 4 weeks. The first 2 weeks is your opportunity to engage with the units, the discussion boards, etc. And I'll talk a little bit more about that in just a second. Week 3, you will then submit a reflective assignment. And week 4, we will then make sure that we take that reflective assignment, mark it and submit it back to you. What then will happen is that we recommend that you work through the learning materials over the course of 4 to 6 months with people within your organisation. The training materials are designed for self-study to allow training to be as meaningful and as individualised, although there is group work, and that's something that we would very much advocate for. You as the facilitator will act as a mentor to learners to encourage them to meet their personal learning objectives by meeting regularly, to discuss the resources, and it also allows the opportunity for learners to reflect upon their own experiences and practices, and link their new knowledge to consider how they would make changes going forward. The structure of this course, for those that have done it before, hasn't actually changed. We can't change the structure of it significantly because of our very proud accreditation with the Royal College of Nursing. But just to provide you very simplistically, that once you're registered, you'll then have access to our online learning environment, which is called Canvas. Very easy to operate, very easy to navigate your way around that. You'll have 2 weeks to engage with the online learning materials, including the discussion boards. The only difference that we will now have is that we expect you to contribute twice per unit discussion. For us, there is a huge difference between a posting board and a discussion board. So we would ask that these discussions take place because, again, as Lindsay has already spoken about, it's how we all learn. And then you'll have the remaining time to submit your reflective assignment and then back to you for marking. So the online content, what does it look like? Week 1, this is then your list of effectively what you will engage in your first week. So an introduction to dementia, an introduction to ageing, which Lindsay will talk a little bit about in just a second. Dementia, the journey, which again is a new unit. It's a combination of a series of the other units that we've had before, bringing them together and looking at aspects of policy and framework that exist to help support people on their journey. The physical and psychological needs for well-being, terminology, because it's a huge thing for me, and what we say matters. How we speak about dementia even can often be the difference between people engaging or not engaging, as the case may be. Communication in dementia care. Dementia, the policy frameworks and the global picture, because that will impact us all. And that's what's essential for us to help inform your practice going forward. And very crucially, another updated and new unit around what is not dementia, because again, we felt that was very poignant to put within the new programme. Week 2 will then see further units, timeline of looking at the person's life and the importance of that. We're then going to start opening up elements of debate and discussion in itself, in and around person-centred versus person-led care, and I'm going to speak a little about that in just a second. Care planning, the underrepresented communities in dementia, meaningful engagement and connection, care partners, because we can't do this without them. The dementia, a human rights-based approach. Now, interestingly, with a question mark, because again, this is a unit that's we want it to get you thinking. There will be quite controversial things within this unit, and that's deliberately put there to change your mindset or just get you thinking a little bit differently and opening your mind to perhaps new elements of reading and research that you might not have come up against before. The importance of understanding palliative and end-of-life care. A very good introduction to our environmental audit tool, or EDAT. And of course, whilst you're here, we would love to be able to keep you here. So an opportunity for you to look at further study here at the University of Stirling and further courses that we would also offer you here at the Dementia Services Development Centre. I'm now going to hand back across to Lindsay so that she can introduce to you a couple of the 2 new units. We're not giving you a lot of information here, we're just teasing you.
Okay, thanks again, Dave. Yes, I'll keep this brief. I've chosen 2 areas that may be of interest, and the focus is mainly on physical health and well-being, with the caveat that these topics are relevant to anybody who's older, including somebody who lives with a dementia. So starting with the introduction to ageing, the ageing process looks at the changes in the body that occur normally with ageing, without any illness being present, why these happen the way they do, and the stresses that can cause significant deterioration in health and well-being. And then the risks associated with ageing and frailty syndrome. Well, the ageing organs and changes to them, along with that comes a loss of function and reserves. So we discussed some of the symptoms in the systems in this unit, but not all. The systems that are chosen are the ones that come with specific risks to safety that we as health and social care professionals in any care setting should be aware of. For example, risks to skin and the physical impact of neurological changes. There's also an introduction to frailty syndrome and an overview of the factors which influence whether a person can be stable and resilient in managing their health and quality of life, or vulnerable to the risk of unmet needs and the onset of ill health. And then when we consider atypical presentations of illness in older people are actually less likely to be diagnosed with illness for a variety of reasons. Unfortunately, sometimes it's due to bias and discrimination, but sometimes it's because the symptoms of illness and the symptoms of natural, or the presentation of natural aging, are difficult to differentiate. But the other thing is that older people can often present with symptoms that are not the same as those that we expect to see in younger people. So, and that's actually especially so for people living with a dementia who can't very often verbalise what they're feeling. So it's important that we learn about this. We'll look at the hidden symptoms and the hidden conditions and some more common symptoms of deteriorating health in older people, for example, myocardial infarction and what's called a silent abdomen. And then moving on to looking at what is not a dementia. Well, we're all clear that with a dementia comes cognitive impairment, but cognitive impairment can be caused by an awful lot of other conditions, including physical causes. And it's important, again, so that older people get the right diagnosis and the right treatment and can have a sense of well-being and quality of life from that treatment, that we can actually identify the source of the cognitive impairment. So in this unit, we look at some of the health conditions that can be mistaken for dementia and the importance of accurate diagnosis of them. Now, we do look briefly at delirium in this, but it has its own section elsewhere in the programme. But we look at common reversible or modifiable conditions like sensory changes. We look at psychological conditions that can include depression, and also irreversible conditions such as lung disease. And then we'll explore some of the medications that can impact on cognition and what to do about them. So each unit has got its additional reading for interested learners that offers more information about what's been discussed in the videos, and additional information for the facilitators to support their learners on the programme. So with that, I'm going to hand back over to Dave, and thanks for listening.
Thank you so much. So now it's my turn, just to give you a little bit of an overview of a couple of the units, again, that we've updated, and a couple of the, both actually, which I've classed as newer units. So we're looking at the first one entitled Dementia, the Journey. What's very clear, and what I should make very clear, is that when I put the bullet point of stages of the dementia journey, we don't mean as in the physical stages of that a person will experience. What we're talking about there is what the trajectory of a dementia journey looks like, but not necessarily looking just specifically at people living within Scotland, for example, where we know we have post-diagnostic support available, but actually being able to disseminate what we know and understand about the importance of good person-led quality post-diagnostic support should mean for anybody living with the dementia, whether you be in Aberdeen or whether you be in Paris. It shouldn't matter geographically where you are. So again, this is an opportunity for us to be able to share some of the learning that we know it takes place within Scotland, of allowing us to be able to hopefully then influence other workplaces and hopefully to a degree even some other countries, getting people thinking differently. What is I suppose the tearjerker part of this unit is the fact that you're hearing voices of people sharing their journey, and we've been so privileged to sit with a number of individuals who are living with the dementia and their care partners and listen to their story. What it just reinforces is the point that for every single one of us, I'm sure we share the same opinion that behind a diagnosis is indeed a human being who's had a life, and their experiences are vital for them to continue to live well. And all I'm going to mention is Joan and Izzy, who share very openly and candidly with us their journey of what it's been like, and effectively calls to a call to action of what they would want from their journey going forward. And it's again just an opportunity for you to be able to sit and hear their story, but again what it means for you in terms of your practice, and perhaps get you thinking that a little bit different. And often what we find is a continued barrier of actually putting research into practice. What we do find within some segments, particularly the health and social care sector, is practitioners' ability to access research. And this continues to be a topic of discussion on a number of different with a number of different clients that we support, but also within the Scottish Dementia Strategy subgroups. And sadly, there are even some parts of research that have informed all of our work going forward, including some of the work that's taking place here at the Dementia Services Development Centre, that sadly still a number of people don't know about. But by default, we perhaps just do it anyway, but we don't ever know where it's come from. So this is an opportunity for us to be able to listen to what people living with dementia are saying, and how can you embed that into your practice. The second unit is, again, getting you thinking about person-centred versus person-led. The whole reason as to why this unit has now been put in is because, not just from a personal perspective, but listening to the voice of lived experience, more and more people living with the dementia are telling us that person-centredness is just branded about now, that they feel that we've lost concept of what true person-centred care means. So what they've asked us to do is change the centred to led, in the hope that that sends a very strong message of, it's my diagnosis, it's my life, I'm in the driver's seat and I always should be. They lead, we merely follow, and we can support and guide as and when they want us to. We're going to look at the principles of person-centred care, and I'm sure we are all aware of what the principles of person-centred care are, but is this enough in 2025? So again, there will be things within this unit that you might look at and think, well, I've not heard of this before. This is completely different from what I've always been taught in relation to person-centred care. But that's then when we'll introduce you to the principles of what we refer to as person-led care and how they differ from person-centred care. Now what we're seeing within Scotland is a shift in policy and practice. So the more and more people that we're saying, actually, we need to stop just branding about saying person-centred care, we need to be thinking more about person-led care. That seems to be picking up people's ears, and people are now starting to pay attention of even just changing it from centred to led sends a very different message. So hopefully these two units will just give you a little bit more food for thought. And again, you'll be able to evidence this within your day-to-day practice. I thought I would just share, I'm not going to read them out, but this is just an opportunity for you to look at some testimonials that we've had within the past. I think what's really important for us to evidence here is that, as I say, I think I've said it a couple of times now, the very wide demographic of people who access the course. We recently undertook a very, very successful project with the Catholic Church. So it was sisters who are supporting each other living with cognitive impairment, ageing and dementia. And we utilised the best practice programme from that. Funnily enough, we just received a really, really lovely report and email from them this morning, which again would be very keen to share in our new course as well. Just the effectiveness of how much the course has meant to them, particularly within countries where they're very resource poor, and sadly where dementia isn't even recognised as a condition. We also share the best practice learning programme not just with clinical colleagues. So we recently undertook a piece of work last year with a housing association, for example, and it was really the first occasion whereby, as a housing association, they came to us, they asked about, they want the best practice guidance. We signposted them to the course, and it's something that they felt has been incredibly beneficial from the top down. So everybody from that organisation took part, from the chief executive to carers within the housing association setups, and again was just hugely beneficial. They felt that it's made a huge difference to their confidence. So we're going to stop sharing the screen for the moment, just to take an opportunity for any questions that have perhaps come through so far, and just get an opportunity to discuss some of these if people feel that that would be beneficial. So accredited with the SSSC, or I think would that be the NMC? So there's not a formal accreditation. What we should say is that things like the Promoting Excellence framework, which is a huge, very positive piece of framework that was developed within Scotland a number of years ago, parts of our course have been mapped alongside the Promoting Excellence framework. Which is, again, our commitment towards ensuring that we're not reinventing the wheel. There's a number of things that we've been able to seek the permission of being able to utilise some of the things that are there, because again, we know that a frustration for people living with the dementia is actually just how many different resources there are out there, as opposed to is there a way in which we can condense everything down into maybe just one resource that will help us to make a difference to our lives effectively. But there's no formal accreditation with the SSSC or the NMC at this stage anyway, but that's something that hopefully we can look forward to in the future. So what would be expected weekly time commitment for the training? So at the moment, the online training is the equivalent of 16 hours of recognised CPD. We do feel that there's a possibility that when we go back to the Royal College of Nursing over the next couple of months, when we show them the updated programme, that would probably increase. I suppose the benefit of having the online-based programme is that it is very flexible. The units, deliberately, we've ensured that there is not screens and screens and screens of reading content, that actually it's bite-sized learning where you can play the video and you can listen at your leisure, but it's enough information to help truly inform then what we would expect if you have assignments and things going forward. As well. So the other question, sorry, I'm just working my way down these questions now. Would the course be useful for a registered manager? Personally, I think it would be, but what do you think? Absolutely. The whole point of this course is that it's accessible for everyone. So again, not continuing to bang the drum of what we're doing within Scotland, but our strategy tells us that when we are providing regular and consistent support to people who are living with a diagnosis of a dementia, what is absolutely essential is for us to have a skilled and knowledgeable workforce. Now, that can be from consultant psychiatrist to a GP receptionist. It's more about, if you have the desire to learn and want to improve your knowledge to help improve the quality of life of people living with the dementia, then in a nutshell, this course is for you. We want it to, and it's not hugely, it's not overly clinical. We've deliberately made sure, and it's not incredibly academic either. Please don't think that even if there is a paragraph of stuff to read, that in every sentence there's a reference, because we've deliberately not made it like that to ensure that it's accessible for everybody, no matter your background and things as well. I think that question's been answered. So Ailey, thank you so much for answering that question. But yeah, with regards to the additional packs, sorry, it was meant to be, why doesn't it link with the SSSC badges? So a very, very good question. Heavily involved with the SSSC in the job prior to coming to the university, and it is a conversation that we would be very happy to have with the SSSC, because, like you say, what we want to do is that element of consistency. But as I say, at this moment in time, we've not approached the SSSC about the course, because I know that as a standalone kind of individual course within a university, I know it's something that they perhaps would be interested in. But again, I'd be more than happy to have the conversation with them, and we can keep you updated with that, because I am aware that if you're already going through the Dementia Ambassadors programme within the SSSC, that part of this learning you might be able to use as evidence for that. So again, more than happy to have a conversation with these. So let me just start looking at, so I work in a hospital. If I update as a facilitator, is this for health care, HC and nursing, or allied health to attend? What level is it aimed at? Who can we facilitate to? I think in a nutshell, you can facilitate to anyone who has the desire to improve their knowledge. So again, you might find that a care home manager, for example, might be the chosen person to come onto the course, but they disseminate that learning throughout the care home. So they'll pick a group of 8 learners. Now that could be both clinical and non-clinical colleagues within the care home. It could be the chef. It could be a domestic. That's the way we would want it to be honest, as mixed a group of individuals as possible. So I hope that answers your question. There's also the opposite of that. We might find that actually a care assistant is the one who's trained to be the facilitator, and they're the ones that are cascading the knowledge to nurses, care home managers. It might be a healthcare assistant within a ward that's the chosen facilitator that the organisation nominates to come forward, and then they disseminate that learning. It's more a case of being able to evidence your learning as a facilitator whilst you're engaging within the programme, submitting your assignment back to us. Once that's marked and we're happy, you're then the facilitator. It's up to you to train who you want to train. Lindsay, please feel free just to interject if there's any.
No, I was just thinking it's not really set at an academic level,
No.
or it's not.
No.
So nobody, like for the SSSC or anything like that, you couldn't say it's level 3 or whatever.
Yeah, absolutely. What would be the expected time for disseminating the training to colleagues? So I think we'd put that within one of the slides. So ideally what we would look for is between 4 to 6 months to give you the opportunity as facilitator, because we do understand that getting people together within an environment to disseminate that learning can often be very difficult. I'm sure I'm preaching to the converted here, particularly within the health and social care sector. Sometimes getting the time to blow your nose can be difficult, although getting 8 people within a room. But we're here to help with that. We're here to support with that. And if you do find that you're finding it difficult to engage with learners within your environment, then please just reach out to us. And if there's any additional support that we can provide, then we will do. We'll work with you. That's what's important, and we're always here to help with that. It's not an issue. So let me just have a look. When do you revalidate from? What does revalidation look like? So at the moment, anything in regards to a revalidation, the revalidation course we're projecting to be released in the autumn. The revalidation course is effectively an opportunity for us to ensure that you as a facilitator have that continued desire and the commitment to continue to facilitate the learning within your organisation. It's also an opportunity for us to provide to you bite-sized updates. So as opposed to having to take the whole course again, if we update the course, for example, in 6 months in a year's time, and you're thinking, well, actually, does that mean I'm going to have to do the whole course? These smaller updates will be included within the revalidation course. So it's an opportunity that at least every 2 years you are getting the most up-to-date content that we can offer. And again, being able to disseminate that research to people where we feel it's going to be essential to. How much of this is taught session? I'm thinking about diary planning. If you have to attend more than one day online, I appreciate other commitments. So there is no commitment for you to attend online training. We don't do anything live, as it were. Everything is online. All the videos are there. All your reading content, your further reading. So everything is online. So it's at your own pace within the time that you have. So please don't think that come the 28th of April, within 2 days after that, you're going to be expected to jump on a webinar and receive an online lecture or anything like that. It's not, and we've deliberately not done it like that, purely because we know what it's like in time when you're in day-to-day practice.
We dip in and out and do the discussion
Absolutely.
board when you're ready and you feel you've digested what you need to read and things like that.
Yeah. So how does the CI, so the care inspector, see this programme? So again, I'm in conversations with a couple of people within the care inspector who are aware of our programme, who are also alumni of Stirling, so they understand and they know the history of this programme. I think if anything, the feedback that we've had so far from conversations that I've had from care inspectorate colleagues feel that this is a very beneficial programme because it's an opportunity for practitioners to be directly informed by research, where we know that, as I said before, a continued barrier for people that are within day-to-day practice is how often do they actually get the opportunity to access what is published research. This is a great opportunity for us to be able to disseminate that to individuals, and then for that facilitator, when they have their 4 to 8 learners, for them to cascade that out. So actually you then got a whole list of people within your organisation that then has the most up-to-date knowledge in terms of the research outputs that not just we as a centre or a university, but the wider both nationally and international context. It's up to us to ensure that you get access to that, and that's exactly what would be expected as a facilitator as well. I'm just trying to pick questions here that perhaps could one organisation have multiple facilitators complete the course, i.e. one nominated person per award? Yeah, so I think that question's already been answered, hasn't it? So yeah, thank you so much, Lorraine, for that. Bless your heart. What is the significance of the 8 people to disseminate to? Is the facilitator limited to disseminating the learning to only 8 people? Yes, in a nutshell, purely because we feel that anything more than 8, the learning starts to become significantly diluted. So actually we feel that 8 is a really good, it's a manageable number. And actually some people are telling us, although that they feel that, like, so you only want 8 people to come on board, they actually sometimes do find it quite difficult in order to even get 8 learners within some of the environments. And we know within staff turnover and things can change quite dynamically, even sometimes day to day. So again, but what that doesn't stop you doing is facilitating one group of 8. And if you have then, amazingly, another group of 8 people all ready to go, you then just start another course, and the packs would be available from us in order for you to do that. So the more the merrier, really. That's our viewpoint of it. And again, we can support with that if you do find, as I say, you've maybe only got 3 or 4 people interested, but you want to try and generate interest, there are things that we can do to help support that as well. So thanks so much for that question. In the meantime, can you continue to facilitate? Absolutely. I think what's really important is what we don't want is to send a very confusing message here for people who are current facilitators that might be thinking, so wait a minute, what does that mean for me? Our viewpoint is that, having listened to the people who are living with the dementia, what is essential here is that we want the most confident, competent and up-to-date facilitators out there disseminating our course and disseminating what they've learned from us. So anybody who has taken the best practice course prior to 2020, we would ask that you complete the whole course again because of the nature of the updates. Out with that, it would then be the case of taking advantage of our revalidation course, which again, the details of that will be released in the coming weeks. The one thing I would definitely ask you to do, if you have the chance to do so, is to go onto the DSDC website and sign up to our newsletter, because that's often where we will put out information in relation to further training dates and any changes we perhaps might be making to different programmes. But Nicola, yes, absolutely, please continue to facilitate, which is great. I think we've probably got time for one more question, so and then we'll stop there, and I can share my screen again just to give you our email address. So how are the learners assessed before they disseminate? So I don't know if you're meaning by the actual learners themselves. So effectively what will happen is the facilitator will take a group of 8 people through the course. They will all be supplied with workbooks. Within that workbook, there is a series of reflective exercises, there's kind of Q&A stuff, but it's your job as the facilitator to sit and work through the units within the workbook. So for example, you might sit and just look at unit 1 for a couple of hours. And it's about having these very open and good discussions with your colleagues. What will then happen is we would then ask learners to submit to you as the facilitator a reflective piece of work. What that then evidences to us is that the people who have gone through the programme when you've facilitated it as a facilitator, that they have learned, and it's actually made a tangible change to their practice. One of the most pleasurable parts for us within this programme is looking at the reflective pieces. I've been able to see just how much of a difference this course has made to people's, even their thinking, terminology, the difference that it's making to people's lives, how they're supporting people living with the dementia day to day. For us, that's what it's all about, and that's the whole reason as to why we do what we do.
And again, just to reiterate, these are not academic essays.
No.
They're not. It's to reflect people's learning.
Absolutely.
Going forward.
And we'll provide you with that, very honest feedback, that if we're looking at something and actually there's another couple of pointers that we can maybe signpost you to, or actually an additional wee bit of learning for you or further reading, we would absolutely identify that. So again, it's about us being here to support you, but it's also about us being able to say, well, yep, that's brilliant what you've done. Now to go one further, have a look at this piece of work and see what you think. So again, it's just giving you access to things that you might ordinarily maybe find quite difficult to access just due to work and day-to-day life, I suppose. We're sorry we've not had a chance to get through every single question, but if there is anything, as I say, specific that you wanted to ask, then I'm just going to share my screen at one final time to let you see our email address, and this is just a conversation that you can have amongst, for yourself or even within your workplace, just to say, right, so we've listened to everything that's on the programme here. We like the look of it, but actually there's a couple of questions, or if you have, submitted a question to us that we've not had a chance to look through or answer, please email us at dementia@stir.ac.uk, and we'd be more than happy to answer as many of your questions as required. I don't think there's anything else that I need to say. I'll just leave that up for just another 5 or 10 seconds or so it gives you the chance to just either take a picture of it or quickly jot it down. And then we'll finish our webinar for the afternoon, and I'll let you get back to doing what you were doing. Okay, so thank you everyone for your time today. We really, really appreciate it. We look forward to welcoming you to our best practice facilitator training and sharing our learning with each other. What we should say is as well as whenever we're hosting training within DSDC, one of the first things we often say is that we're here to learn just as much as you are. So we will be learning a lot from you too, and be sure that we use that learning to help then inform what we do going forward. So if we feel that there are maybe little tweaks or changes that we have to make to the programme, then we will absolutely do that. It's about us making sure that it continues to be accessible and is up to date and appropriate for you as possible. So thank you so much for your time and for your attention, and on behalf of everybody here at DSDC, we look forward to hopefully seeing you very, very soon, and take care. Thank you.